let's go ahead and get started. I'll continue to let people in as we go, but I am excited to introduce Dr. Lindsey Fry to the open forum tonight. And we are very happy to hear all about fascia. I've heard bits and parts of this lecture and I was enthralled with it. So I said, can we do this again, please? So Dr. Fry is part of Team Red Sage, the integrative practice in Fort Collins. And they do amazing things for pain management and restoring mobility to these pets. Great place to visit and learn. I hope I can get back there at some point in time. But from there, I'll let Dr. Lindsey Fry introduce herself and share her knowledge, which is amazing.
Well, thanks. That was a lovely introduction. Well, I'm super excited, and Cindy heard me give a lecture about this at CRI and got excited about it. And of course, I felt like I needed to pack in a whole bunch more. Um, so I found some super cool new papers and some new things that are coming out because this is kind of a hot topic on the human side. And I probably put thoroughly way too much in here. And it's fun as a small group. If there's something we want to talk about more, like there's total flexibility here, but it is chock full. But I did try to make a really good reference list at the end, so that everybody, and most of them are open access. And if there's one you want that's not open access, just let me know. I have all of them. But wanted to really point you to some of this new stuff that's coming out that feels really exciting. Okay, so for tonight, I want to do a quick review of fascia, a little bit about anatomy, and then the cellular and molecular structure and kind of what makes fascia function. I want to focus in a little bit on the innervation of fascia because this is a really important underlying piece to not only the pathology that we see, but also how we can potentially intervene. So we're going to spend a little bit of time on that. And then I want to talk about this cycle between fascial health and mobility, nociception and chronic pain, and this kind of cycle that we end up in when we have lack of mobility or chronic pain or something like osteoarthritis, and how fascia gets tied up in this cycle. And it's really critical to target the fascia to help break that cycle. We'll talk a little bit about clinical assessment of fascia. That could obviously be an entire course. It is out there. And then focus in on shockwave as far as interventions for improving fascial health and breaking this cycle. So really quick, a brief fascial overview. So this is the system of connective tissues throughout the body. It encases everything, our organs, our perineum, it's all over the place. We're going to focus mostly on the musculoskeletal fascia, but it's not unique to that system. There's many, many varieties. We're going to talk mostly about deep and superficial fascia and probably ultimately focus mostly on deep. And there are some others that we'll skip for tonight. But basically, all of this fascia is made up of the same basic ingredients. So we have collagen, we have this extracellular matrix, and then we have this small but very active and mighty cellular component. So we'll dive into those a little bit. And each of them vary depending on what that fascia's job is and where it is in the body and how it's supposed to function. So real quick, this is an image from a cool, really cool and interesting system of papers out of Copenhagen where they're actually looking at fascia in animals, specifically dogs and horses. And so these images, I have a few from those papers and I'll share it with you guys. But this superficial layer is more superficial, not a big surprise. It's kind of that enveloping layer you can feel just beneath the skin. It's very elastic. It's highly integrated into adipose tissue. But what's really interesting about it is these red and white lines that go up and down show that there are these septa that connect the superficial fascia to the deep fascia. And not only does that provide a mechanical connection, so that if you push and pull on the superficial fascia, you're also pushing and pulling on the deep fascia, but also metabolic and cellular messengers can move along these septa. So we can target and affect deep fascia by interacting with superficial fascia. So we don't necessarily have to go all the way deep. So the deep fascia is where a lot of the really interesting stuff is. This is where we have the nerves and the vessels, kind of more innervated type fascia. This is the fascia that can be real stringy and kind of open and loose to allow things to move really well, really wet fascia. but it allows for gliding and movement between all these body parts, muscles, between muscles and tendons, muscles and muscles, all kinds of things. So this is the real lubricating fascia. But what's really, I think, a key take home for us who are trying to interact with fascia is that these layers communicate in a lot of ways. And this is just an ultrasound image looking at fascia. I feel like we've all probably seen ultrasound images, but aren't really looking at this little piece. This is from a human leg, but you can pull out that small image and see the skin and then the little layer of superficial fascia, some adipose tissue, and then that deep fascia is that thicker layer. And so you can assess fascia with ultrasound, and I think we're going to get better and better at that with time, but mostly we're relying on our hands at this point. But just, we've all probably seen this before, so wanted to highlight where those layers are. So as we start on this kind of zoomed out view of fascia, we can't talk about fascia without talking about posture and the tensile support that fascia gives us. So if a dog was just this skeleton, right, and we stood all these bones up, it would just completely collapse. There's nothing holding it together. And fascia, far more so than any other tissue, even muscle, provides that tensile strength that links all these bones together and lets them resist gravity. And primarily that's what posture is, how your body can resist just turning into a puddle on the ground with gravitational forces. And so we can't have posture, we can't resist that without fascia. So it not only sustains our posture when we're sitting or standing or moving, but it also helps maintain or hold a position when we stop and ask an animal to do a therapeutic exercise where they're holding a position for a while. That job actually ends up falling more on fascia than it does on muscle, which is kind of interesting. Oh, and I just wanted to throw in this image. So this is a toy. So if any of you are parents, you've probably seen these, but it's basically springy elastic that's connecting these wooden dowels. And some of the strings are connected to each other and some of them aren't. So you learn about fascia when these strings break or they lose their elasticity or they get tied in a knot, that the structures right next to them are really affected, but the structures further away are still impacted, but to a lesser degree. But you can kind of imagine this squishy toy as we talk about fascia. So this is a paper out of the Penn Working Dog Center that I really, really like. And I think is some of the first published information we have on posture in dogs. But these images I feel like are really helpful, and I actually have them printed out and will show them to clients. But it has some nice examples of good, normal, healthy posture and then abnormal posture. And whenever we have abnormal posture, the gravitational pull on our fascia is going to be asymmetric. So we're going to end up with fascial dysfunction. And we have all seen this, right? And so changing a dog's posture lets whatever therapeutic exercise you're doing or whatever postural change you're trying to make be much more effective over a period of time, because gravity is going to be working on them all of the time, you know, outside of your therapeutic exercise session or fascial session that you're working on. But these are just some nice images I wanted you guys to have from this paper for assessing posture. So we can't really think about posture and fascia without this concept of the fascial chain. And this is that paper. This is the group in Copenhagen who's working on outlining fascial chains in dogs and horses. And they're doing these incredibly detailed dissections where instead of how we did dissections when we were taught anatomy and you just threw the fascia into the trash can, they're throwing the muscles into the trash can and tracing where these fascial planes are connected through the entire body. And similar work is happening in humans where we're identifying these fascial chains, and dysfunction or injury to one part of a fascial chain will impact the entire fascial chain. So kind of like that springy little toy. But I encourage you guys to take a look at this stuff. They've got some really neat, the horse section is a little bit further along than the dog section, but they're both coming along, and it can really change the way you look at how a dog is moving and how you assess their fascial relationships. So take a look at those for sure. So here's that toy again. You start to see where the strings are attached and where they are not attached inside the dog as far as fascial chains go. Okay, so then digging in a little bit more, there's obviously a strong connection between fascia and muscle. So then there must be a connection between fascia and how we move. So fascia is integrating all of the muscles, and it allows for communication, or what we call interoception. So how these muscles, the way we think about proprioception and our awareness of our body in space interoception is sort of the body's awareness of itself against itself. So does a muscle know what a different muscle is doing? And fascia turns out to be the communicator that allows that to happen. So if you need muscles to co-contract or not co-contract, relax and contract at the same time, fascia is integral in that communication between those muscles. So to have a fluid movement where muscles are working together to achieve one ultimate movement, fascia is really critical for that connection. And then those connections impact the whole rest of your body and how your body adjusts to that motion, shifting your weight to the other leg if you're going to balance and those kinds of things. And that's where that myofascial chain and communication well away from the area that's moving or contracting also needs to respond. So this is how that communication is happening. And then there's the big communicators. Our neurovascular tracts also travel through fascia. So dysfunctional fascia can impact those as well. So to kind of highlight this even a little bit more, these are some really interesting numbers, mostly from human studies on fascia, but 70% of muscle fibers have a tendinous insertion. So that's what we're kind of taught in vet school, where we learn origin and insertion and action, right? So that's the tendinous action of that muscle. But 30% of these muscle fibers aren't going to a tendon, they're actually going into fascia. 40% of muscle tension moves via fascia in neighboring muscles and tissues, not the primary tendon. So we have a pretty big chunk of these fibers and then the actual tension getting distributed through fascia. And this is really important. It's a safety mechanism that the body's developed, because we reduce this direct force of transmission on the tendon and we spread out the area of stress of a muscle contraction. And then it also lets us appropriately coordinate muscle movements. So really having healthy functional fascia makes you stronger and makes you more able to move. And then this concept of interoception and exteroception. So are muscles aware of each other? And are they aware of what's immediately outside? So the fascia tells you that, like what's touching you, how do you need to move in relationship to that, can be really integrated between muscle groups and areas of the body. So this is a cool image from a recent paper I found that's actually studying fascia in astronauts who are in space and aren't weight bearing for a long time. But I just wanted to show you this. They highlight that this muscle is this low tensile strength thing. Then we have the myofascia, which is the epimysium is what we call that. And it links right into that tendon, but you can see how it's dispersing some of that muscle fiber tension and force. But it's a super cool, it's long, but it's a great paper to share with you guys. Okay, so as we talked about, this healthy fascia helps take some of the force transmission off muscle, take some of the work off muscle. And so fascia makes us very efficient. And it actually, dogs are better at being efficient when they're fascia than humans are. And you can see it in their anatomy a little bit. But if we think about fascia having elasticity, almost like a rubber band, as we stretch and deform fascia, we store some potential energy. So this is that kangaroo or catapult effect. So dogs can stretch their fascia and then access that kind of when they jump or when they're trotting or doing a pacing gait. There's not a lot of muscle bellies in those distal limbs. And if we look at studies on range of motion during pacing and trotting, they do quite a bit more in their distal limbs. And they're really leaning heavily on that potential energy of the fascia. The fascia has more flexibility and mobility than muscle. So muscle, as it contracts and relaxes, works in a very regimented racket-like ratchet is what that's supposed to say, like fashion, whereas fascia actually has much more dynamic movement capabilities. Another place we see this, so I talked about trotting and pacing, is in amputees, especially hind limb amputees. So if you look at the studies we have on how they move differently, they become very dependent on this potential energy in their fascia and are more at risk if that fascia becomes diseased or non-functional or sticky or thickened and those kinds of things. So this fascial mobility is very intimately related to muscle strength and function, and then also overall function and mobility of that patient. So take home point number one, to kind of sum up that first part, so fascia is really critical to mobility and links all movements in the body, in addition to maintaining posture during stasis. Fascia is a major contributor to comfort and efficiency in the musculoskeletal system of dogs and how they move. So if we want to address any of these things like mobility and musculoskeletal system and comfort, we cannot ignore fascia. All right, so let's zoom in now that we've talked about fascia from kind of a outside view, and let's look at it from a tinier structural standpoint. This paper is called Hyaluronin and the Fascial Frontier, and it has some great images, but here you can see we've zoomed in on this fascia. We can see the deep layer with the tighter stacked fibrils, a loose layer where we have some cells mixed in, some hyaluronic acid mixed in, and then the superficial layer that again has that tighter fibril alignment. So the cells we see, there are more than this. This is an abbreviated list, but these are the ones I just wanted to highlight today. Big player are these fibroblasts. So that's that purple cell in the image. So they reside in very close proximity to the collagen fibrils and have a very strong relationship with them. They really help maintain the structural integrity and organization of the fascia. They themselves have an incredible ability to very rapidly change their shape. And they're very sensitive to pressure from the outside. They respond to things like pressure, massage, stretch, pull, and they will change their shape. They'll change what they're making. They'll change what they're excreting into the extracellular matrix. But there's this very intimate relationship between the fibroblast and the extracellular matrix that movement of the fibroblast can impact. They're strong communication cells, so they make a lot of cytokines. They communicate with other cells within the fascia quite a bit, so they kind of dictate what's going on. And this last part, this one paper I read calls them the janitor. They're the janitors of the fascia. So they clean up old debris, they put everything where it's supposed to be, they help stuff line up, and they maintain healthy turnover and healthy regrowth of fascia and reorganization of fascia. So if your fibroblasts aren't functioning well, or they've kind of gone into stasis, you won't have healthy turnover and recovery in your fascia. Myofibroblasts are a lot like fibroblasts. They don't do as much of the maintenance work, but they have more expansile and contractile properties. So this is how, and I'm sure you've all experienced it, when you're working on fascia and you feel it respond very, very quickly, that's probably mostly myofibroblasts. So they can act a little bit like muscle and act a little bit like fibroblasts, but they have this strong contractile and relaxing capability. Fasciocytes are a new one, aptly named, cells of the fascia. And they, in addition to fibroblasts, are making HA. Turns out they're making most of the HA, so they function like fibroblasts. For a long time, we assumed it was the fibroblasts making the HA. Maybe a combination, it's a little bit debated. But really, these guys are playing a critical role in making sure that we're maintaining the ability to glide within the fascia and between fascial layers. So these cells are existing within the extracellular matrix. And I used to say that it was kind of like Jell-O, but it's not really like Jell-O. It's more like this toy called a Nido. Have any of you guys seen a Nido? I highly recommend you get one. So I have 2 kids, and so I see all these cool toys, but it's this really weird texture, and it's squishy, but it can be firm, and you can warm it up and it gets more squishy. But I think it I think it really represents how the extracellular matrix can feel better than Jell-O. But it's this gelatinous type substance that's very responsive to outside forces and temperature. Mostly water, so 90% is water, but we also have these gags and P-gags in it. So these proteins that help give it its viscosity and elasticity, turgor or squishiness. And they hold water where it's supposed to be or keep water out where it's not supposed to be.
Sidetracked.
So our big player there is HA. So they're hyaluronic acid, most abundant by far. Lubricin works in conjunction with HA, and they form this kind of viscoelastic gel that enhances lubrication even more beyond just controlling where the water is. What's really interesting about the fascia, probably more so than anywhere else in the body, is this very fast and very intimate relationship between the extracellular matrix and the cells that make up the fascia. So the extracellular matrix can change what the cells are doing very quickly, and the cells can change the extracellular matrix very quickly. So that's why we often see very quick response to things like shockwave or acupuncture or trigger point work, things that we're doing to interact with the fascia. So HA, I just wanted to dig in a little bit more detail on this. I think I've got the structure of HA here. So it's this structure that has all these little combs, these hydrophobic combs on it that help keep water kind of caged in and maintain the health of that extracellular matrix and the fluidity in that extracellular matrix. Interestingly, we're learning it does more than that. So it also helps mediate cell proliferation, helps cells move as they need to move, can help promote angiogenesis. Turns out it can be pro-inflammatory or anti-inflammatory, and also helps with immune response. So immune cells actually move through the fascia quite a bit, in addition to the blood. And HA really helps maintain cellular mobility through the fascia. They're produced in the cell membrane of those fasciocytes. And as they break down or as they get injured or worn out and not cleaned up, like if they're not cleaned up in time by normal fibroblasts or normal macrophages, they become pro-inflammatory. So broken up HA is very pro-inflammatory. Healthy, normal, high molecular weight HA is anti-inflammatory. So that becomes kind of critical as we're trying to manage HA health within the fascia or within a joint. Okay, so now we're going to dig in a little deeper. This is another image from a paper I'll reference quite a bit, but you can see we've got this zoomed out version of the fascia. Then as we zoom in, we've talked about these collagen fibers, the fasciocytes, but then there's also all these little nerve endings that are moving through this fascia. So I want to talk about how the fascia is innervated. And one thing that I think is really interesting, and we certainly aren't taught, but the greatest input into your central nervous system, so your spinal cord or your brain, the most sensory information in your entire body actually comes from fascia. So not your eyes, not your ears, not vision. The most sensory input you get is fascia. So all throughout the body, it's very, very richly innervated with sensory afferents. And these sensory afferents are wrapped and related to these collagen fibers. And then we have these looser areas, and that's where our big, the big primary nerve tracts are running. But these little tiny free nerve endings are integrated all throughout the fascia. There's also a whole bunch of specialized sensory receptors. So this is where we have all these specialized proprioceptors that tell us about all kinds of different things. So push, pull, stretch, tension, and even autonomic function. So sometimes when you're working on fascia or moving fascia, you'll feel nauseous or have almost autonomic responses to your fascia. There's also whole studies on like emotional elements within fascia, but the autonomic nervous system is also integrated throughout the fascia. So you can explain it very easily. But sometimes that's why fascial work is very uncomfortable, beyond just being painful or, nociceptive. What's interesting too is the distribution of these receptors is far from uniform. So around joints and around myotendinous junctions, the number of proprioceptive receptors goes way up. When you have disease or inflammation, the number of nociceptors goes way up. And we'll talk more about that coming up here. But if we're trying to target the innervation of fascia, it makes sense to try to target areas where we know it's more richly innervated. So at these myotendinous junctions, joints, those kinds of things, those areas. So nociceptive fibers, so another sensory input that the fascia provides to the central nervous system, also exist all throughout the fascia. A delta, so our fast, well-differentiated pain, can come from fascia, and then also kind of our slow, poorly localized C fiber type pain can also come from fascia. These free nerve endings that are thinly myelinated and small are all interwound into the collagen fibrils. And of the C fibers, so there are these peptidinergic C fibers, which we'll talk a little bit more about, but they are more likely to produce these proteins that can potentially cause local inflammation or signal local inflammation to the nervous system. Substance P and CGRP are the big two, and we'll talk about them in a little bit more detail coming up here. And then the ends of these fibers are where we have all the variation in our trip channels. And these trip channels will really dictate how much information is coming from the periphery to the central nervous system. And so these areas of fascia can become highly nociceptive generating, so they can generate pain themselves. And these mechanoreceptors, or those proprioceptors that we were talking about on the last slide, if fascia is getting stretched beyond its limits, or pulled to where it shouldn't, or it can't move, like if it feels sticky, those proprioceptors transition to being nociceptors. So suddenly you were getting proprioceptive input from your movement, but now that movement instead is giving you nociceptive input. So we recruit these proprioceptors to give nociceptive information. So fascia can really make something that was small and shouldn't be super painful into a big painful problem pretty quickly, just with not being able to move. So again, just like we talked about with proprioceptors, the density of free nerve endings or nociceptors is not the same and is highly dynamic in the fascia. And they've done some really cool studies on both humans and mostly rats and mice, where they actually take samples of fascia from different areas of the body, and the number of free nerve endings are highly variable. So they vary by location, but then they also vary by disease state. So more than most other tissues, when there's inflammation or pain, the number of free nerve endings can increase anywhere from like 100 to 1,000-fold in certain areas. So the amount of information that's coming can go way up. And the images of this are wild. It's like pre-injecting something that's inflammatory, there's like 1 or 2 free nerve endings. And then they have these histopath images of after, and it's just like solid nerve endings. And it happens relatively quickly. And so again, if we're going to be targeting, looking for these really rich areas can be really beneficial to be more effective with whatever modality we're trying to use. So this leads to some of the symptoms we see in chronically painful patients, like hyperalgesia and allodynia, and it helps explain how they're happening because our receptor field, so what nerves are being involved and what nerves are sending information into the central nervous system, are expanding. And then the region of the spinal cord that's receiving that information, so the target segment area of the spinal cord, is also getting bigger. So if we're going to target our treatments there, we want to understand that it's likely spreading to other spinal cord segments as more information is coming in. So this is this concept of neurogenic inflammation, which I think is really interesting and kind of a sad thing that can happen. But if you have an injury, and I think, let's see that, and that injury is taken care of, it goes away, it's healed, whatever that trauma was, the splinter is out, the surgery is done, whatever it may be. And the tissues themselves are no longer generating inflammatory mediators. There's actually an anterograde activation of the nerve from the dorsal root ganglion, which is the cell body of the nerve, primary afferent, that's up by the spinal cord. And it says, hey, no, we're still inflamed. And it sends the signal down, so we're moving the wrong direction, and makes that nerve start releasing substance P and CGRP into the peripheral tissues. So it kind of creates its own inflammation when there actually isn't any tissue damage or reason to have inflammation. And so we're potentiating a pain state that's not there. So this is a real problem and a real factor in chronic pain states. And happens quite often. And it seems like the fascia is especially prone to this happening, probably because of how dynamic and responsive these free nerve endings are. But we start potentiating a pain state that no longer exists. So we maintain peripheral sensitization and therefore can't get rid of central sensitization in these pain states. And this neurogenic inflammation in the fascia is potentiating that. So to talk about fascial pain, we've kind of covered this, but when the fascia can't move, when it gets sticky, or when it gets stretched beyond its limit, we really increase this nociceptive input. So sick fascia becomes painful very fast. We increase the input that's coming from that peripheral region into the nervous system by increasing the number of free nerve endings, creating neurogenic inflammation. But basically, we start potentiating that peripheral state. And then we see changes in the central nervous system. We see central sensitization. And it starts to just feed on itself. So the patient couldn't move because XYZ, they had osteoarthritis, they have intervertebral disc disease, whatever it may be. Their fascia gets sticky, then they get more painful, then they want to move even less, then their fascia gets more sticky, and it just becomes this impossible cycle to get out of. Oh, there's that. Okay, so take home point number 2, fascia is highly innervated and contributes both proprioceptive and nociceptive input into the central nervous system in a big way. Fascia can generate its own pain and enhance central and peripheral sensitization. And the innervation is dynamic and by disease state and not homogeneous through the body. So we can be more targeted in our treatment. So myofascial pain syndrome is very well recognized and described in human medicine, although they would probably argue that it's not, but compared to us, they're pretty far ahead. But this is a recent paper that came out, and it's very exciting because I think it lays the groundwork for us to start talking about it, communicating about it, and potentially trying to publish more research on it. So I recommend this for you guys to look at. This is just a quick synopsis over here, but I wanted to highlight that they talk about what is myofascial pain syndrome, how do we recognize it, what are the consequences, how do we diagnose it, and then how do we treat it. And Shockwave gets a whole section in the treatment section of this paper. It's short, but it's there. So it's exciting that in sort of this groundbreaking review type article, Shockwave's already mentioned as a potential treatment. But I think if we all start learning this language and using it more, we'll move this area of veterinary medicine forward. So fascia is this highly plastic tissue that hopefully we've covered. And its mobility and function depend on a whole bunch of factors. And we've talked about them on a small scale, but this is a nice diagram from a paper that talks about all different kinds of things that can impact just the stiffness of the fascial tissue. And obviously, as fascial tissue becomes more stiff, it's less mobile, so you get more nociceptor involvement. And we don't need to go through all of these, but you can, we'll touch on a few of them that hopefully we can help impact. But again, I just want to stress this really interesting relationship between the cells of the fascia and the extracellular matrix, and having both of those be healthy is important for the health of the other. And Shockwave will help us with that quite a bit. And that maintaining normal, healthy fibroblasts to maintain normal, healthy fascial turnover and recovery is also really important. So a few of those factors from that diagram that I tend to think about the most is, do we have direct inflammation or injury in that fascia? What's their use, disuse, or overuse looking like in areas of fascia? What does their posture look like? What's the impact of gravity as they're just standing, just sitting, just laying, even moving, but looking at posture? Do they have a big scar, right? A scar is fascial tissue that's just trying to heal and has kind of gotten disorganized and thickened. How is temperature affecting them? And how can I use temperature to impact fascia? So I'm not going to dig into this too much, but obviously warming fascia up gives it more mobility and elasticity. Cold makes fascia tenser and less mobile. Age, we'll dig into age a little bit because I'm sure we all deal with aging patients. And medications can impact fascia in both directions. Corticosteroids impact fascia. Hormones impact fascia. So thinking about what medications is this dog on that might be impacting their fascial health. And then metabolic disease can really impact fascia. And we're learning more and more about how a lot of cells and metabolic mediators bypass the blood and are actually moving through fascia. And there's some interesting stuff about disease in fascia, metabolic disease in fascia, even fever in fascia. And like the achiness you get when you have a fever is actually more related to fascial pain than anything else. So kind of some interesting stuff there as far as other diseases impacting fascia. So let's talk a little bit about inflammation and injury and how it impacts fascia. So in an acute setting, often inflammation or injury to fascia is short-lived and very reversible. You get a release of inflammatory cytokines, macrophages come in, They clean stuff up, they move to M2 macrophages, they rearrange, everybody heals, and it's kind of over. You might have some sensitization of those nociceptive afferents, but not a ton. But if we have prolonged inflammation, so long-term inflammation because of an inflammatory condition like osteoarthritis or repetitive loading that's creating low-grade continuous inflammation, this can change. So we end up with a chronic presence of macrophages in the fascia. They're not moving through the inflammatory pathway like they should, and they kind of get stuck in this early phase and can't move through. We start getting a release of things like IL-1 beta, TNF alpha, and other fibrogenic cytokines. And fibrin makes things sticky. So this just makes the fascia get stickier and stickier and stickier. And it gets thicker and thicker and thicker because it's not getting cleaned up. The janitors are not doing their job and rearranging everybody and getting things organized. That's when we start to develop this neurogenic inflammation. So we get a release of those antegrade peptides coming out of the nerves, kind of perpetuating this inflammation, even if the injury is gone. And what you see over here is we get this accumulation of short chain hyaluronic acid. And that becomes pro-inflammatory in itself. And we lose mobility even further because we've lost the healthy HA that used to exist between those layers of fascia. So all of this leads to reduced mobility in that fascia. So aging, and this is really interesting because there's a lot of stuff out there on how aging affects and changes fascia. But when you're young, or when fascia is young, you have this really nice lattice, springy, healthy organization in your fascia. And as you age, you lose some of that. And it becomes more haphazard. You get more random cross linkages. And a lot of this has to do with chronic use, chronic injury, chronic stasis, non-movement. You start to impact your fascia more globally, and you lose some of the glide. There's also baseline inflammation. Like everybody always has some baseline information. When we're young, it's very low. And there's this phenomenon that they describe called inflammaging. So as you age, your baseline level of inflammation is just higher. And it's harder to maintain healthy fascial mobility as your baseline level of inflammation just goes up and up and up. So knowing that that might be something our older patients are dealing with helps us understand why their fascial health is not rebounding as well. So this is an image of kind of what that looks like. Here's the young, healthy girl jumping rope. Her fascia is nice and crimpy. It's well organized in that lattice formation. And then as we age and sit around, we get this more haphazard organization in the fascia. And also we lose that crimping or springiness. So we lose a lot of the potential energy storage that fascia had. So why is this bad? What are the consequences? We can eventually get fibrosis. So this is a little dog named Princess who had really bad elbow osteoarthritis. And her elbows basically eventually got stuck in that position, being really, really rigid and straight. So reversing her fascial changes got really difficult. So tissues start to tether, they start compressing neighboring tissues, we lose that mobility. We can even see tethered nerves, which can be incredibly painful. Interestingly, we also see changes in circulating inflammatory factors as we lose fascial mobility. So a few studies have looked at TNF alpha levels in human patients who have low back pain, which is primarily caused by fascia. And their systemic inflammatory markers are higher. So not only are we impacting the physical and mechanical, but we can impact the inflammatory and metabolic status of a patient if fascia is not moving and is not healthy. Then if we go back to that concept of the fascial chain, not only are we affecting Princess's elbows, but her shoulders, crisscrossing down her back, the opposite hind limb. We see this whole fascial connection and we start to impact her fascial mobility remotely as well. So this kind of sums up what we've talked about as far as what we see with changes. And these are all things we see in our patients in rehab practice or in any kind of practice. We see things like muscle stiffness, muscle weakness, muscle dysfunction, pain, and loss of proprioception. Like I would say those are probably the most common things that we're dealing with. And you can see how fascial disorders contribute to all of those things. And then I just overlaid our diagram from earlier where once we start being stiff and not being able to move, we activate more nociceptors. We initiate peripheral sensitization. We start enhancing central sensitization. Then we want to move even less. And we just end up in this vicious circle that we can't get out of. And fascia actually serves to potentiate that cycle instead of stop it. And so we end up with that snowballed effect that leads to worsening of all these clinical symptoms that we're trying to manage. So take home point number 3, fascia is highly plastic and sensitive to many contributing factors inside and out of the patient. These mostly reduce mobility of fascia due to adhesions and getting sticky, and changes in organization. So these lead to commonly managed conditions or symptoms that we're dealing with in our patients: loss of proprioception, muscle weakness and stiffness, and obviously pain is a big issue. I threw this in here because it's, I think, a really interesting concept. So pandiculation, and this is what this dog is doing, and probably right now what we all want to do as we talk about sitting and being still. But this is the involuntary stretch of soft tissues as we transition between biological cycles like wake and sleep or stillness and movement. Yawning, sometimes it's called the yawn stretch yawn complex. So yawning is a special form of pandiculation where you're actually stretching and moving the fascia of your face and neck. And it's built in to help you be able to breathe, and maintain that mobility there. So often that's why patients will stress yawn. And one of the coolest ways I heard it described is fascial flossing. So you wake up in the morning, you do your fascial flossing, and animals have it really naturally ingrained. Humans have sort of culturally weaned it out of ourselves where it's sort of inappropriate to do that as you move around, but we probably should be. It also feels really good. So stretching your fascia, you get a big upregulation of feel-good neurotransmitters like oxytocin, dopamine, serotonin. So part of why animals will also do it in times of stress to help calm them down. But it's this corrective response and kind of fascial maintenance that these dogs do on their own. And so often, and I'm sure you've all experienced this is one of the things we see go away as patients develop pathology. They'll stop stretching because it hurts or they can't. But then it's also one of the things we see start to come back as we restore fascial health and mobility. They'll be like, oh, he's doing down dogs again, and I haven't seen him do that in so long, I hadn't even noticed. So it's a good thing to get tabs on. So I have this video. This is a patient named Cash who had multiple hemilaminectomies, and had stopped stretching. And the client noticed, he said, I think he wants to stretch, but he needed help. And so he figured out if he went over to him and just kind of like gave him a little lift, he would almost always want to go right into a pandiculation stretch. So see how he goes, oh. So Jeff, his owner, figured out that he could like give him access to his pandiculation with a little support. And I just thought that was kind of a cool thing. So this could be an entire course as well, right? So fascial evaluation, I think, and something I think we are all always getting better and better at, but hopefully understanding the anatomy of fascia and the function of fascia will help inform your exam a little bit. But really, we should be assessing fascia in any exam that we're doing. We should be looking at posture, both when they're static and when they're moving. We want to look at flexibility and mobility. Balance and proprioception are part of your fascial assessment because we know that most of the proprioception on how they're moving is coming from their fascia. So weakness in balance or weakness in proprioception can flag a fascial issue. How strong are they? How conditioned are they? How are they in their fitness or athleticism? Are they stretching at home? How are they moving at home? Are there movements they don't want to do or that have become restricted or painful? Various levels of palpation, from light to deep, and knowing what kind of structures you're targeting as you palpate that animal. And then looking for pain red flags. Do we have areas of hyperalgesia that seem far more painful than they should be? Or places that shouldn't be painful that are? Is that possibly an area of neurogenic inflammation we should be focusing on? Is their pain responding as we would expect with their known pathology? And do we start using ultrasound? I actually was curious about that. Like, should we be looking at fascia more commonly with ultrasound? And there have been some studies on the human side that show that palpation is actually better or potentially more diagnostic than ultrasound. So keep practicing and use your hands because they're actually the best tool you have in these assessments. So if we find or if we suspect fascial dysfunction, what are our goals for treating it? So obviously, at the root of the problem is lack of fascial mobility. So that's how those nociceptors get turned on. That's how we prevent movement. We lose all kinds of things. So we'd really like to restore that mobility, restore neural gliding, restore neuromuscular control. If there is inflammation, whether it's neurogenic inflammation or an inflammatory condition or disease or direct injury to the fascia, we'd like to reduce that. If we could reduce the nociceptive input that's coming from that fascia, it's such a huge generator that if we can reduce that, we would improve peripheral sensitization and central sensitization. Can we improve that janitor function of those fibroblasts? Can we say, organize these collagen fibers, clean up the mess? Let's get this more functional and healthy again. Can we reinitiate that process to promote healthy repair and healthy recovery of fascia? We need to look at the whole fascial chains and address function in the entire fascial chain. And then we also need to address whatever's causing that fascia to become sick in the first place, right? So do we need to be more aggressive about managing their osteoarthritis? Do we need to work on whatever the underlying cause is? Fascia is usually symptomatic, so we have to be addressing it alongside whatever the primary pathology is. And we're going to focus heavily on shockwave today, but clearly managing fascia takes a multimodal approach. So we're going to use all kinds of modalities together to try to adjust fascia for that patient. So this is a patient who is laying on a PEMF bed, getting cupping and acupuncture and e-stim. So just an example of addressing some myofascial issues in a patient. Okay, this is also the complete Cliff Notes version of what shockwave is, but figured I was preaching to the choir a little bit, and you have access to a lot of this information. But basically, we're putting energy into these soft tissues, including fascia. And it's this biphasic pulsed acoustic wave, right? So go into all the details of that. But this energy moves through the tissue, and a few things happen. We get cavitations in tissues and cells. And then we also have dissipation of energy when we change acoustic impedance. So when we move from one density of tissue to another, some energy gets dissipated, right? So that goes into the tissue that's in that area. So that is the very quick summary of that. But this I thought was really interesting. This came from a paper that I'll show you guys. But it talked about these 4 phases of response to shockwave. And it was one of the nicest summaries I feel like I've seen. So I wanted to share it with you guys. So this is pulled directly out of that paper. But we see a physical change initially. So there's this cavitation, changes in cell membrane permeability, ionization of molecules, and increased transport. So that happens quick. Then there's this physiochemical change. So we start to see biochemical reactions in response to that. Upregulation of ATP, more energy in the cells, activation of cell signaling pathways. Changes in chemical function, primarily in the form of ion channels. So we start mobilizing calcium differently and changes in cell signaling. So all of that happens with the end product being these changes in biological behavior. We start changing what those cells are doing and making. So we change the cytokines they're making, we change the chemokines. So who are they telling to come over? We change angiogenesis, and that's how we get these anti-inflammatory effects. So we kind of wake up the cells, but these steps that happen to get there, I think, are really interesting. But it was just a nice description of that. And fundamentally, what we're talking about there is this process called mechanotransduction, right? So we're taking a mechanical stimulus, putting it into the tissues, and looking for a cellular response. And that's what we see. And as we said earlier, fibroblasts are the best cells to try to target when we're trying to induce mechanotransduction because they're so highly responsive to mechanical input. And so we can see that shockwave will stimulate fibroblasts, and we can lead to this fascial remodeling, production of vesicles, which I'll talk a little bit more about, and move to more normal function. And by improving the function of fibroblasts, we improve the quality of the extracellular matrix. And when the extracellular matrix is healthier, it keeps the fibroblasts functioning more normally. So we create a cascade that's moving in the other direction. So we promote the health of both of those things. We see changes in HA, changes in lubricin, changes in fascial turnover, and changes in the organization of fascia. And all of these things are the underpinning of why we see the clinical changes we do when we treat with shockwave. And what I think is really interesting about the shockwave research, and I don't know if Cindy agrees with me on this or not, but it's almost like shockwave got thrown into the clinics and we started using it and we started trying to figure out what conditions to use it on and how much to do. And we would see all these well-documented clinical improvements, but we didn't always know exactly why they were happening. And now there's this cool kind of second wave coming through that says, okay, we see better fascial health when we do shockwave, like what is happening? And now there's this kind of move back to the lab where we're looking at, okay, why is it happening? So this is a really cool, fairly recent paper that's come out. And they were actually looking very directly at what shockwave was doing to fascial fibroblasts. So these were fibroblasts from human fasciolata grown in a culture, and then they treated them with shockwave and monitored them for 24 hours. And what they were looking for was, are they actually changing how they produce HA? Are they changing how they're interacting or producing collagen? And how does that change over a 24-hour period? And this was really cool. So only 1 hour after shockwave, they started seeing these vesicles. So these are these little buds forming kind of within that square. So the cells start making stuff and doing things. And then they basically went and stained these cells, and I think I have an image of it here. So they took a variety of stains and looked at the cells. So this is the first thing they stained for, and they were looking for HA. And you can see the control cells are in A, and then B, C, and D are various time points, I think 1, 4, and 24 hours. And at 1 and 4 hours, the cells get really brown. So they start making a ton of HA. So they're staining for HA. And then at 24 hours, they start to see more brown out in the extracellular matrix. So these cells are making little vesicles of HA and then shooting those vesicles out and dissipating them into the extracellular matrix. So they're making healthy normal HA and putting it out into the extracellular matrix. They were also rich in 2 types of collagen, collagen 1 and collagen 3, type 1 and type 3. And the cool thing about that is collagen type 3 is what really signals the fibroblast to start initiating recovery and repair and organization. So they start making more collagen fibers and organizing those collagen fibers. So they also stained these vesicles and cells for those types of collagen, and they were also rich in those. And so I just thought this was super exciting and very cool, because now we're actually seeing, okay, if we treat these cells with shockwave, they are in fact making more HA, they are in fact making healthy collagen again, and they're stimulating fascial recovery and repair. So this is taken right from that paper again, but we see this release of HA into the extracellular matrix. So this suggests, obviously this is in a dish, that we're increasing hydration and lubrification of the fascial tissue, which is critical to good fascial function, and likely improving this fluidity of tissue and facilitating gliding in that deep fascia. So then I think this is kind of cool. If we know that's happening, they just didn't look beyond 24 hours, but we know that that's changing as quickly as 24 hours. So what do we want to do with those patients once we've shockwave them? I don't think we want to stick them in a crate and have them rest, right? We want them to move because we've just improved their gliding. And if we can have them move after we do shockwave, we can change that distribution of nociceptors back to proprioceptors. We can improve that gliding and function. And normal gliding and function improves production of not only HA, but also lubricin, which is the next thing I want to talk about. But getting these patients to move after they have shockwave, I think, is even more critical now that we understand what's happening. So lubricin, we actually knew more about before that HA study. And we know from some rat studies on Achilles tendons that when we treat that area with shockwave, we see an increase in lubricin. And lubricin buddies up with HA to make that real gelatinous kind of sticky substance like the nido, that allows that gliding in the deep fascia. And it also, we see lubricin get upregulated in athletes and people who are moving their fascia a lot, and it helps kind of protect from wear and tear. So now we know that using shockwave on fascia increases both HA and lubricin, which is pretty exciting. So let's talk a little bit about how it might impact inflammation. And I don't know about you guys, but when I was first introduced to shockwave quite a while ago, there was this thought that you're actually inducing inflammation to try to promote healing. And I think that that's maybe what we thought was happening, but as we are learning more about it, it seems less and less true, that we're actually creating an anti-inflammatory environment. So we can influence inflammatory cell behavior and cytokine behavior with shockwave. And one of the coolest things that we see happen is we encourage this shift from M1 to M2 type macrophages. And that happens in the normal path of inflammation, but chronic inflammation often gets stuck with macrophages in sort of the pro-inflammatory M1 phenotype. And as we move to M2 phenotype of macrophages, that's when we get things like tissue repair, cell proliferation, angiogenesis. And there's some really interesting studies on shockwave showing that we can move macrophages into that M2 phenotype when we're in inflamed tissue. So we basically help that cycle of inflammation move to its next more healing phase. And this, I think we see the most when we're trying to treat tendinopathies, and tendons are a type of fascia, right? Where they're kind of stuck. They're stuck and they kind of need the boost to get through the rest of their inflammatory recovery. And a lot of that is probably related to macrophages. And as we talked about earlier, when fascia gets inflamed, macrophages hang out in it for longer. So we just have this population of macrophages sitting there. This also happens in the synovium of joints, right? It gets infiltrated with macrophages. And if we can shift those to an M2 phenotype, will help mitigate inflammation. Those M2 macrophages produce a very different profile of cytokines than the M1 phenotype did. And they are the more anti-inflammatory cytokines, IL-4, IL-5, IL-9, IL-13. So we've seen those be upregulated after shockwave treatment in the lab setting. And now we understand that that's probably because we're shifting this macrophage distribution. We ultimately see less white blood cells in the fascia after shockwave, so less inflammatory cells. And we can see this upregulation in stem cell function. So we move to this healing phase, kind of an anti-inflammatory healing phase, and an upregulation of growth factors kind of in conjunction with those stem cells. So I think this is actually probably more of what we're doing and less of this sort of thought that we're creating inflammation to try to induce healing. I think we understand that better now. So kind of that stem cell and tissue healing stuff is a big focus in this paper, but this is a really nice paper looking at regenerative medicine and using shockwave in conjunction with regenerative medicine in musculoskeletal disease. So I pulled a few of the highlights out of that to share with you guys, but they focus quite a bit on angiogenesis or new blood vessel formation. So VEGF is a big player in that we see elevated. But by improving angiogenesis and having more blood vessels, we basically get more good things like blood flow to an area to promote healing. So that's why it's good. We see a reduction in edema and swelling, a reduction of those inflammatory cells that have moved in, like we talked about. And all of these things set up the right microenvironment for tissue repair to happen. So tissue repair can't happen in a inflamed, gnarly environment. And so kind of the crux of this paper is how does shockwave change that microenvironment to be pro-tissue healing and tissue recovery? And they're very interested in this stem cell activity, and we do see this increased stem cell activity. And again, we see this collagen 3 production, which kind of turns those fibroblasts on to reorganizing and cleaning up and maintaining that fascial health. This is a summary of everything we've just said from this other paper, but I just kind of want to move to this part because I think it's so cool. So this is a really interesting paper on the behavior of fascial nociceptors when we treat them with shockwave, and it's just crazy. But treating pain and fascia is really important. I feel like I've beaten this dead horse. That's what this slide is about. Just like we've got to treat fascial pain to have good mobility and to maintain good mobility. So we have to break that cycle. So how is it doing that? And that's what this paper summarizes really nicely. But one of the coolest things is we see a reduction in CGRP and substance P after shockwave treatments. So we are directly addressing that neurogenic inflammation, which is very hard to treat and very hard to manage. But there's really neat evidence that if we have that antegrade production of these, shockwave reduces those in the periphery. So we can break that cycle of neurogenic inflammation. And that seems to happen both peripherally and also at the level of the dorsal root ganglion. Then, when what this image is of that I think is so interesting is nothing else does this, but shockwave will selectively destruct these sensory-free nerve endings that are really upregulated in that fascial tissue. And these two images, the dark black where the asterisks are is like a big healthy, not a tiny free nerve ending, but a big nerve. And you can see the myelin there. And then the little black circles are thinly myelinated free nerve endings. And then on the other side is when they're treated with shockwave. And you can see the normal nerves maintain their myelin sheath. And these free nerve endings are just gone. They just go away. And I just think that that is mind-blowing. And that we have a modality that will selectively choose for these free nerve endings, reduce their number, and sort of get them neuroplastically to a more normal state. And I just think this is wild and so interesting that we can directly impact the nervous system to change this hyperalgesia that has happened, change the input that's going into the central nervous system, and really address these neuroplastic underpinnings of chronic pain. And I just thought this was very exciting and cool. So I want to make sure I got to that for you guys. So as we reduce these free nerve endings, we reduce the sensory input that's going into the central nervous system. We reduce that burden. And that's kind of step one of how we can act centrally. Also, this bombardment of nociceptive input that we get with shockwave really upregulates serotonin and activity in the periaqueductal gray in the brain. That's the primary region that is responsible for descending inhibition or modulating pain input from the periphery. And so we can also retrain these patterns in the central nervous system that have contributed to this chronic pain state and turn them down and sort of return more to homeostasis. So very, very exciting as far as analgesia goes in using this. This is a really nice summary. Bess Pierce talked about this paper quite a bit, and I loved it. And I just threw it in here so that you guys would see this is a lot of the stuff we covered. We didn't even get into this osteogenic stuff, which is fine because we were focusing on fascia today, but it's a nice summary of stuff we've covered. And then I just put this in here because now we can break this cycle. This is a summary of what we just went through, but what I'm hoping to get to is, okay, well, it comes right after this slide, but when we're thinking about using shockwave on a patient who we suspect has fascial mobility issues, these are things I think about as I'm planning for shockwave. So what's their underlying fascial health and mobility? What information did I gain from my physical exam? What information did I gain from my pain assessment? Where did I find thickening, pain, or stickiness in their fascia? What else do they have going on that would contribute? So what are their specific mobility issues? How old are they? What's their level of inflammation? What drugs are they on? What's their metabolic state? Do they have hyperthyroidism? Are they cushingoid? What else is going on? What are their use and disuse patterns? Where do I know fascia is going to be the most juicy and I can have the biggest impact? And where else in their body might they be impacted from this primary fascial problem? Then I'm going to choose where to shockwave. I'm going to choose my intensity and dosing. I'm going to choose how often to do it. And a lot of these have question marks, but we're starting to develop systems for making these kinds of decisions. I'm going to assess my patient's response as I'm treating them, like what's their area of maximum intensity of response to the shockwave. I'm going to decide how I'm going to decide if they're getting better. So what are my outcome measurements? What are my assessments that I'm going to be following up on? And I'm never going to want to forget to also be addressing whatever the primary pathology is so that we don't end up in the same fascial dysfunction cycle that we were already in. So a quick review of energy flux densities. These are nice to just have in your head, especially if you're going to look at literature, because they'll often talk about low, medium, high. And the shockwave units are nice. The new ones will actually tell you the density, depending on which head you have on, which I find incredibly helpful. But just wanted you guys to have this for reference because I feel like I was always looking it up. And then this is from that paper. This is a slide I thought was going to come immediately next, but this is pulling from the human literature and looking at sort of treatment guidelines for various conditions, and is a nice reference if you're starting to try to develop this in your mind. Okay, I have a patient with back pain. What might be a starting place? And of course, you'll adjust to manage that patient's individual needs. But this is a nice chart to have from that paper to reference on what we know on the human side. And again, I can't stress enough that using shockwave is magical and wonderful, but it's part of a multimodal plan. And all of these things can just build on the effectiveness of your shockwave treatment. And now that you have an understanding of how it's working and how it's affecting not only the extracellular matrix in the cells, but also the innervation, you can get more out of these other modalities when they're paired with shockwave. So that feels super exciting to me. Here's that list of references. So you guys have it. Some really, really cool stuff in there. And here's my corgi dressed up as a Swiss Army knife to send you on your way. So thanks. Sorry I had to rush a little bit at the end, but again, all of it's there and those references are there and are super valuable to have on the ready. So thank you guys so much. I hope you learned something new about fascia and a new thing about shockwave and fascia, and that you feel excited about using it.
Awesome. Amazing. Thank you very much, Dr. Lindsey.
Yeah.
As always, there is a ton of information, you guys. It will be recorded and posted on the website within a couple of weeks, so it will be there for sure. And I know it's a little late, but any immediate questions and any other questions we can address via email. So any immediate questions before we run off to the next place of our life? I think everybody has a lot in their brain right now, which I do too. So, guys, if I can always connect you with Dr. Fry. I can always do my best to answer some of those. I did put a bunch of stuff on fascia in our newsletter that came out on Sunday. Not nearly this in depth, but so much for us all to learn. So thank you for your time. Thank you, Dr. Fry, for your time and your knowledge. It's recorded, so we can all spend some time reviewing and building our knowledge base.
Yeah. Well, thanks again for having me. It was great to have to dig in a little deeper again. So
I love it. So much to learn. That's what
yeah.
keeps going. That keeps me going. So thanks for your time, everybody, and have a great night.